A warm welcome to this webinar on the role of Oseltamivir in flu management. Sponsored by Hitro, brought to you by Hitro. Hitro Healthcare, as you know, is an innovative pharmaceutical company with 30 years of excellence and 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, API, and FDFs in the world. Hitro Healthcare is a 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation. And we have the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hitro Healthcare, the pioneers in antivirals, offered Fluvir, that is Oseltamivir, Favipiravir, and Remdesivir to the patients, for which they received an award of Pharma Excellence in August 2020 for COVID drugs. Today's webinar on role of Oseltamivir in flu management, we have moderator Dr. Pramod Jog. Welcome, sir. Dr. Sainath Pawar and Dr. Kiru Mahajan. Welcome, Dr. Pawar. Welcome, Dr. Mahajan. Dr. Pramod Jog, as we know, is Professor of Science, Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee Member GAVI CSO 2016 to 19, and Chairman Mini Recipe Model IIP, author of Ology. Dr. Kayur Mahajan is MBBS DNB Pediatrics, Pune, Diploma in Pediatric Infectious Disease, Oxford, UK, Pediatric Infectious Disease Consultant, Pune. Dr. Sainath Pawar is MBBS, MD, DCH, and FCPS, Fellow in Allergy and Asthma from University Hospital of Leicester, UK, Certified Pediatric Flexible Bronchoscopist by APPS and IIP, Consulting Pediatrician and Pediatric Pulmonologist, Consulting Allergy and Asthma Specialist, President Kolhapur Academy of Pediatrics 2024, National Trainer for NTEP IIP Action Plan, National Trainer for Pulmostar IIP Module, National Trainer for IIP REAP Module, Executive Board Member for Maharashtra Respiratory Chapter of IIP. With this, I welcome all the doctors to this meeting and hand over the session to Dr. Pramod Jog. Over to you, sir.
Thank you. I hope I am audible.
Yes, sir.
And I will just start sharing my presentation. Just give me 1 minute. Yes. Okay, I hope my screen is visible.
Yes,
and
sir.
I am audible.
Yes, sir.
Thank you.
Yes, sir.
Thank
Yes,
you.
sir. Yes.
Okay. So today we will be discussing a very important and interesting topic of influenza and the role of oseltamivir in the management of influenza. And I have two influencers of influenza. One is Dr. Sainath Pawar from Kolhapur and Dr. Kayur Mahajan from Pune. And you can see the moderator, Dr. Pramod Jog, that is myself. I have been the presidential strain of Indian Academy of Pediatrics of 2016. And you all know that the nomenclature of influenza virus is like, it has the place of origin, the month and the year of origin, and the name of the strain, and so on and so forth. So my name has been put in that particular fashion. Okay. Now remember that the monsoon is in full swing, and there are three entities which are very happy during monsoon. Of course, the farmers are very happy, the frogs are very happy, and of course, the physicians are very happy. And of course, the pharma industry is also very happy, because when doctors are getting patients in large numbers, the sale of medicines is also on the higher side. So these are the people who are very, very happy. But children in the season of monsoon are really not very happy, because many times problems like influenza, dengue fever, gastroenteritis, and hepatitis, they galore, and children many times are unwell. Parents are, that's why, worried about their children. And whenever someone says it's viral, earlier I used to be, rather little casual. I said, okay, don't worry, it will be all right in 3 days. But days have changed. When someone says that it's viral, many times, I start thinking as to what is the type of virus, whether the onset is with cough and cold, or whether it's onset with headache and muscle pain and weakness, or whether there are, symptoms suggestive of dengue fever, and whatnot. So we have gone through the pandemics of influenza and COVID, and that's why these viruses, which are typically the RNA viruses, they are the ones which are known to change, their structure very rapidly. It makes us worried. Okay. So when a 3-year-old boy came with fever, cough, cold, and progressive breathlessness for 3 days with tachypnea and low saturation and acidosis, and a picture suggestive of ARDS, admitted to PICU, ventilated, and even oseltamivir along with supportive therapy, and who turned out to be H3N2 positive, we started wondering whether early oseltamivir in this child would have prevented all these problems. Okay, and that's why in a previously healthy child presenting with cough, cold, and fever, progressing over 3 days, whether every patient like this should be given oseltamivir, particularly in the flu season. So that is some important question that we are going to discuss today. And there are some other points which will be discussed. I have enlisted them under the title of confusion because they are the confusing points about flu. So the question is whether this infection is bacterial or viral. If it's viral, which is the virus, whether it is rhinovirus, adenovirus, influenza. If it is influenza, what is the type, whether it is H1N1 or H3N2, and then whether I should start oseltamivir upfront, and whether I should give it to every patient to play safe. Okay. So there are quite a few healthcare related challenges in monsoon, as I mentioned. And in case of influenza, the cases of influenza and the deaths due to influenza, they have been rising. And the influenza and related deaths are alarmingly increasing in India. So one should know that influenza A is the one which is responsible for frequent epidemics due to the minor antigenic variation. Every year we know that the composition of the influenza vaccine changes, and that is mostly because of some of these viruses which change their structures, and they show their predominance in certain parts of the world. And we all know that influenza A, which includes H1N1, H3N2, these are also responsible for the periodic pandemics. And influenza B viruses, they infect only human beings, and they only cause local epidemics, while influenza C is a mild infection. Okay. And currently circulating subtypes are H1N1 and H2N2. So we all know that there have been four major global pandemics, and that's why we are worried about influenza. So 1919 was the initial pandemic. Then there was 1957, then 1968, and then 2009. And all of these, the pandemics were related to major shift in the structure of these influenza virus. So Kayur, I have one question to you as to what are the recent updates in the epidemiology and the circulating strains of influenza viruses affecting the pediatric populations in India?
Uh, as we know, there were mostly four circulating viral strains, which most of the vaccines include influenza A, two strains, and influenza B. Now, influenza B Yamagata strain has not been circulating, so WHO has recommended to remove it. So, what mostly we are seeing right now is influenza A, and in that too H3N2. So most predominant circulating strain according to ICMR surveillance also, and what we found in our routine IPD cases also is H3N2 most of the times, sometimes H1N1 also, and sometimes influenza B Victoria. So these are the three strains, but predominantly currently H3N2 is circulating.
And do you think that there is any difference in the severity of presentation in between H1N1 and H3N2?
Presentation, like clinical presentation?
Yes.
No, sir. No, that not much difference between the presentation of H3N2 and H1N1. So, but what we currently are seeing are patients with very high grade fever, starting at 102, 103, and they are lasting for 5 to 7 days. And many children are presented with febrile seizures also, and along with other GI symptoms also.
Right, right. I can understand. So, we all know that those who have flu, they can spread it to others up to about 6 feet. And these viruses are spread mainly by the droplet infections when one coughs or sneezes or talks. And that's why one should remain away from the affected person. And particularly if the person is sick, he should try and stay at home. And it's also important to wash the hands with soap and water. And as we have been discussing, there are two glycoproteins on the surface of the influenza virus. They are HA and NA, hemagglutinin and neuraminidase. And HA is the molecular key. That means when the influenza virus enters into the respiratory system, it gets attached to the respiratory epithelial cell with the help of this hemagglutinin. Okay. And then the virus enters inside the respiratory epithelial cells, and then it produces its own copies. As I told you, it's an RNA virus, and then he wants to come out of the cell and then infect other cells. Okay. So when he wants to get out of that particular cell, this neuraminidase is the one which is responsible for a certain molecular level actions at the exit, and that is exactly the place where oseltamivir works. Okay, oseltamivir is a neuraminidase inhibitor. We'll be seeing quite a few details about this molecule today. So remember that these two, HA and Na, are the important glycoproteins. And what you should remember is that HA, hemagglutinin, is the molecular key which is responsible for attachment of the virus to the epithelium, and Na is the molecular seizures, which is responsible for all those small little virions which have gathered to get out of the cell to infect other cells, and that is exactly the place where all those different virions get separated. Okay, so Dr. Sainath, I would like to know as to what different clinical scenarios with which influenza virus can present in pediatric population. In short, when to suspect influenza infection.
Yes, sir. So basically, generally, as sir has already said, that patient will come generally with as a routine cough, cold, fever. Nowadays, they are coming with high grade fever. So if the child is, if it is routine viral, normal child will get settled within next 2 to 3 days. Actually, if the child is not settling after 2 to 3 days, fourth, fifth day patient is not settling, still there is a high grade fever. And generally, what we are seeing that generally, if this influenza virus specifically, these children will be of thoda sa little, they become little drowsy or not playful, and this type of pattern we generally see that patient initially was having fever, cough, cold, then thoda sa fever may come down, and the child become drowsy, not feeding well, not playing well. Then there is a scenario that we should think positively, think of this influenza, and then there is a time either you send the swab, or if the patient is not happening, in our area, if the patients are not happening, we can go for the directly oseltamivir treatment also.
Okay, and I'm sure some of these patients, they
Or
may
any
present.
or any
Yeah.
patient who is not responding to treatment like antibiotics, we are not, he is not giving adequate response, then also we can think of this. But especially drowsy patient, keep your antenna up and think of influenza virus.
Correct, correct. And I always say that influenza is the father of all those influenza-like illnesses, because that headache and myalgia and weakness are so prominent that I call it as a systemic illness. It's something not remaining localized to the nose. Like a rhinovirus will produce only runny nose, mild fever, and it will disappear on its own in a short time. But then influenza will create much more, systemic involvement. And you can see that the febrile seizures, encephalopathy, myocarditis, and gastrointestinal symptoms like vomiting and diarrhea, they are also seen as the atypical or the severe presentations. And the weakness persists. Quite a few patients coming to the OPD, they are saying, sir, the child is so weak for the last 5 days, 6 days, 7 days. What to do? What to do? What to do? And the parents are really, really helpless. Okay, so if we can see, there are quite a few, different symptoms like fever and myalgia, cough and lack of energy, sore throat, and breathlessness, and the loss of smell or loss of taste, diarrhea, headache, which are seen in all those viral infections like influenza-like illnesses, H1N1, severe acute respiratory infections, and COVID-19. And we all know that there are differences, in individual viruses, but in general, most of these respiratory viruses will present with fever and cough. And depending on the type of virus, there could be a bit of difference in the presentation. But influenza does present with, severe, problems like high grade fever, maybe sudden onset with chills and myalgia, and as I said, uh, headache and weakness. Okay. So there are certain emergency warning signs of flu in children. If at all this child is breathing very fast or has cyanosis or not taking the fluids properly or is drowsy or sometimes the opposite side, like so irritable that he doesn't want to be held. Okay. So these are some of the important symptoms which are alarming symptoms. Okay. Sometimes these symptoms improve, but they return with fever and very bad cough. And some of these children, these days presenting, they initially have high fever, fever settles, but then the cough begins. Okay. And sometimes we see that the illness shows what is called as a biphasic pattern. And there are some complications of flu, like acute respiratory infections like pneumonia and ARDS, acute otitis media, absenteeism from the school, and absenteeism from the office leading to lack of amdani, that is income, and antibiotic abuse. So all these starting from alphabet A are the complications of flu. So one should be aware that any child coming with acute otitis media might have had flu, just in the last few days. Okay, a child coming with presentation like pneumonia might be having flu at the back, and ARDS also. Okay, we all know about the general treatment of influenza. And in case of influenza, the division of management has been done in categories A, B, and C, and we are going to see it in details in a short time. And as I told you, neuraminidase inhibitors like oseltamivir and zanamivir, they are the ones which block the viral neuraminidase enzyme, which I told you is important to act at the exit gate, like the watchman or the gatekeeper. He will not allow all those children who want to get out of the gate and go out onto the road. No. So this oseltamivir will block the exit and it will not allow the virions to get out. Otherwise, if these virions get out of the house, they will go and start infecting others' houses. And that is exactly the place where oseltamivir acts. And that is why it stops, it halts the spread of the infection, because it stops the spread from one cell to other. Okay. And that is why even if you give little late in the course of illness, this severity of the illness is reduced. There is another group called adamantines like amantadine or rimantadine. They interfere with the hydrogen ion channel activity of the influenza virus, and these are the ones which block the entry into the host cell, but they are active only against influenza A viruses. Okay, this oseltamivir is a potent and a selective inhibitor of the neuraminidase enzyme, as I told you, and it's a prodrug which is converted into the active form oseltamivir carboxylate in the liver, and it inhibits influenza virus replication and pathogenicity and prevents the further spread of infection. And it is effective against all the strains of influenza A and B. Okay, this is the grammatical or diagrammatical representation of oseltamivir and the mechanism of action. And you can see that the release of the new virions from one virion has been blocked by neuraminidase. Oseltamivir was the first oral neuraminidase inhibitor, and it is approved in more than 100 countries. So, Dr. Keyur, there is a question to you as to what are the current recommendations for the use of oseltamivir in OPD and the IPD, in the outpatient and the indoors, and what are the different categories for the treatment of influenza?
So categories according to the Indian government guidelines also divided into category A, B, and C. Category A is uncomplicated or mild cases where patients are having mild fever, cough, sore throat, but without much body ache, headache, diarrhea, vomiting. So these are the milder patients who we routinely see in our OPD. Those just need paracetamol, hydration, and monitoring. Category B are high risk for severe symptoms. These are patients with high grade fever, severe throat pain, and they may need home isolation and treatment. And also patients who are in category A but having pre-existing high risk illness, like especially those less than 2 years of age, pregnant, over 65 years of age, then those are having chronic health issues like lung, heart, liver, kidney, or neurological or immunity deficiencies, on long-term steroid therapies. Those with category A symptoms also come in category B. And then category C is including the patients of category A and B also, but they are having signs of breathlessness, chest pain, drowsy, low blood pressure. So basically those who require IPD treatment. So those patients come into category C.
And then, can you just give the summary of the treatment guidelines?
Yes, as said, so category A, we need to just give symptomatic treatment and monitor them. But at the same time, we should ask them to come follow for OPD because we don't know when the category A will land into category B or category C. So it's just not like that. We should give them medicine and send them home. We should we should counsel them what are the warning signs, when to come back to OPD, when fever is now subsiding, when other symptoms are coming. So for smaller children, we should ask to follow up them on after 24 or 48 hours. Category B, as we have discussed, very high grade fever, severe sore throat pain, and the current epidemic or current epidemiological scenario is saying that there is viral influenza like illness or influenza epidemic or the season is going on. In those seasons, we can straight away start with oseltamivir. Okay, and preferably within 48 hours. Testing usually is not indicated in category B. We can start them without testing also. And category C, as we all know, these patients require indoor admissions because they are in severe forms of influenza illnesses, and they will need investigation also. They will need antivirus and other supporting measures.
It's very important to note that the category A is treated with isolation, bed rest, plenty of fluids, and paracetamol for fever, while testing and oseltamivir will be required mainly for B and category C. So Dr. Keyur has already made it very clear, and we will of course discuss it in further details with the help of some cases also. Dr. Sainath, will you just like to mention about the dosage and the recommendations of oseltamivir?
Yes, sir. So basically, so dose is in adults. If you are going to, it is divided into two things. Like one, first is treatment, and second is a prophylaxis, chemoprophylaxis. Treatment is generally for 5 days, and chemoprophylaxis is for the 10 days. So in adult, it is 75 milligram capsule twice daily, is the standard treatment dose, and for prophylaxis, it is 75 milligram capsule once a daily. In children's, it basically depends on the weight. So if the child is less than 15 kg, it is 60 milligram per day divided twice daily. And chemoprophylaxis is like 30 milligram once daily. So 60 milligram is equal to 5 ml. So basically the dose will come for treatment 2.5 ml BD or 2.5 ml OD for prophylaxis. For 15 kg to 23 kg, generally the dose will be 90 milligram per day divided again twice daily. And for prophylaxis, it is 45 milligram once daily. If you count in ml, so it will be 3.75 ml BD for treatment and OD for the prophylaxis. From 23 kg to 40 kg, it is 120 milligram per day divided into two doses. And for prophylaxis, it is 60 milligram once daily. So that means 5 ml BD for treatment, 5 ml OD for the uh, prophylaxis, and if it is child is above 40 kg, so the it is 150 milligram per day divided into twice daily, that is 75 milligram BD. So if you want to give syrup, it is 6.5 ml BD, and for prophylaxis it is 75 milligram OD, so 6.25 ml OD. And if the child is able to take tablet, we can give tablets also. And infants 2 weeks or less than 1 year of age, any weight, we can give 3 milligram per kg twice daily. And prophylaxis generally not advised in this age group. So 0.25 ml per kg is the dose for infants actually.
Very good. So one should remember, yeah. Yes, you want to say anything, Saina?
No, sir. No, sir. Yes.
Okay,
Finish.
thank you. So the question is, Dr. Sainath, you have mentioned about the schedule and the dosages. So how does this early initiation of oseltamivir, because Keyur told us that one has to start it within 48 hours of diagnosis or suspicion. So how does it influence the clinical outcomes, including the duration of illness or progression to severe disease and complication rates in children? And whether we can give oseltamivir for a child admitted with LRTI, that is low respiratory infection with distress and H1N1 positive on day 4 or 5 of illness. Because on one side we say that it is useful only in the first 48 hours. But if a child comes little late and gets diagnosed little late, can we give this medicine on day 4 or 5 of illness? That is the question.
Yes, sir. Yes, sir. So basically, it is always better to start if you are suspecting a H1N1 like illness. So it is better to start the oseltamivir within 48 hours of symptoms, or when patient is visiting a doctor, because it reduces the illness duration by almost 1 to 2 days. It decreases the risk of complications such as pneumonia, encephalitis, secondary bacterial infection, and it lowers the hospitalization rates also. So early treatment is always associated with better recovery and with a fewer complication, we can say. But if the patient is coming to you late only, if the patient is admitted somewhere else and is coming to you at around 4 days, 5 days, so it is always better to start it. Whatever benefit it may give a little lesser benefit that early treatment. But always, whenever there is a suspect and whatever the day of illness, you better start it. That is the dictum.
Okay. So if you go through some of the clinical trials, there are quite a few benefits of the empiric and the early use of oseltamivir. So in patients with influenza, oseltamivir reduces the antibiotic use by 26%. It also reduces the lower respiratory tract complications and hospitalizations, and also the occurrence and the severity of pneumonia due to H1N1. Also, there are some guideline recommendations. So WHO has categorically stated that empiric treatment is recommended and the treatment should be started as soon as possible, and the laboratory confirmation is not necessary for initiation of therapy. And even if the lab test is negative for H1N1, it does not exclude the diagnosis in all patients. And therefore, early treatment is very, very important, and an early empiric supportive therapy and monitoring is very, very important. And in adults also, similar benefits have been found. So now, Dr. Keyur, what is your opinion as to whether incidence of viral infections in general over last few years, maybe after the COVID, whether it has increased, and what are your, rather thought processes related to the possible reasons for that?
Yes, general behavior of any viral infection had changed after COVID. The symptoms of viral infection are more severe. The fever is lasting long. Usually, initially, we used to see viral fevers which go on 3, 4 days, maximum 5 days. Nowadays, any viral fever, especially influenza-like illness fever, lasts for 6 to 7 days. So it lasts longer. And the fever is really very high at 102, 103. What we are seeing right now in Pune, so children are having day one, they start with 102, 103 fever, and that continues for 4, 5 days. The parents are very anxious, and we have to counsel them repeatedly that this is viral, this will take time. So yes, the duration and severity of viral fevers have changed. Now, as there is surge in viral infections, yes, what we clinically see, there is definitely surge in viral infections. The reasons we are not very sure, but what we can see, there is increased uptake of pneumococcal vaccines. So other pneumococcal based infections have now reduced because the government has also started the pneumococcal vaccines. So these bacterial infections have been taken care of. So now, because something is taken care of, nature simultaneously what say the compensatory mechanism to increase some other viruses. So illnesses are definitely there. So definitely yes, over the period of time we are seeing more and more viral illnesses, and now because we have got better diagnostic modalities also, so that's why we are also getting those cases diagnosed as viral illnesses. Previously what happened, that we were not knowing this is viral or bacterial, we used to give medicine and somehow the child used to respond. So we don't know whether that was bacterial or viral. Now because we have now the doctors have also become more educated, more conscious, more what's antibiotic uh, so what's that? So to real terms, they are
Aware,
giving us
aware.
these antibiotics. So that's why we can see definitely there is some surge in clinical scenarios of viral illnesses.
Okay, that's great. Anyway, Dr. Sainath, in
Yes, sir.
case if you have witnessed some cases in your practice which you would like to
Yeah.
share, I would now request you to just
Yes,
present a few
yes, sir.
cases, and then we will have some questions and answers in
Yes, sir.
general related to influenza.
So I will present only two cases. One is a IPD cases, and it is not a very critical cases as we have shown in your presentation. It is a routine case, but how we can like get a clue. So I'll just discuss two cases, and so this is our first case. She has a 3 years old female child. She was admitted with cough since 5 days, dry coughs, cold since 6 days, and fever since last 5 days, high grade intermittent. She was admitted, when she was admitted, her clinical parameters was like heart rate was 125, respiratory rate was 35, child was tachypneic. She was having some respiratory distress. On examination, respiratory system, there was bilateral occasional clefts and bronchi. So the provisional diagnosis when patient came was LRTX. Basic investigation was done. So she has got a HB of 11, WBC count of 3,500. So here one of the clue we can get here that there is some WBC count is on lower side. And nowadays we are seeing this type of patient, like typically coming with low leukopenia and maybe sometimes thrombocytopenia also. So here, if you see the differential, the lymphocytosis is there, lymphocytic predominance is there, platelet is also little on the borderline. CRP was normal, which may be showing that it is less of bacterial, not always like that, but somehow like not very severe bacterial infection. So now we had done an X-ray. You can see here X-ray. So there is some definite haziness on the right side of the lungs. So we are saying that there is some LRTI part is definitely there, either maybe bacterial or viral. Maybe here, as the reports are suggesting, we are thinking of more of viral. So he was started on antibiotics. He was started on NEB. He was started on oxygen as baby was tachypneic, having respiratory distress. But somehow he was not maintaining very well on oxygen. So he required a high flow settings for maintaining his oxygen saturation. The child was little irritable also on the O2. So then we started on high flow oxygen. So somehow after high flow oxygen, child was comfortable. Then slowly next day tachypnea reduced. But again, day 3 of admission, the patient become drowsy. It was again sick loop, not accepting feeds. So at this time, as the patient was critical, we have sent the H1N1 swab and which was positive. So then the patient was started on Oseltamivir and slowly over next 2 to 3 days patient has improved. So this was our first case, which has given a clue that WBC less, then patient later become on drowsy. So that was a clue that this may be a viral infection, and then we had done a swab which was positive. So another case, this is a OPD case, 1-year-old Raghav. He was coming to OPD as a routine patient, cold since 4 days, cough which is dry type of cough since last 2 days, fever since 2 days. So no other complaint. So we had just treated as viral. He was feeding well. He was playful at this moment. Child was treated symptomatically, some paracetamol, some anti-cold, and yeah. So not antibiotic was also given because at this moment just 2 days of fever was there. So patient was sent home. Again, patient came after 2 days. Then mother is telling that child's fever is reduced, but cough cold is still there and significant cough cold is there, but child is not playing. So if the in what happens in normal patient, if the normal patient that fever has gone, that child become playful. But here the fever is less, but child is not playful. He is weakened, activities decrease. He is not playful. So we had done a CBC on this child. HB was 9.2, WBC was 4,500. Platelet was 2,80,000. Relatives has additionally done a dengue report also, so which was negative because they thought ki they are there, so they had done the dengue report. But here platelet was normal and WBC count was low. Lymphocytic predominance was there. As the patient was not very affording, so we have decided to start on Oseltamivir here because patient has become drowsy, and slowly then after actually we are supposed to admit, means we are trying to admit this patient, but patient parents were not willing that time, so they said we wait for next 24 hours, and slowly patient also improved. So activity improved, child become playful, fever also gone, activity better, so patient got better, and we could avoid the admission also of this patient. So this was our second patient, which was OPD patient. First patient was our IPD patient. So these are two common scenarios that every pediatrician will come across this type of cases. And now is the this all these cases are like this only. Yeah, thank you, sir. Any comments, sir? Jokes, sir? Anything you want to add on, sir?
No, I think it is good that you have shown the prototype cases of indoor as well as the outdoor. That's very good. Only I will ask you one small little query which always comes in the practice is, many times children come to us and we start with antibiotics like amoxicillin or amoxiclav, and after 4 or 5 days, as you showed in one or two cases, sometimes the diagnosis of influenza becomes evident after 4 to 5 days. So our pediatric colleagues many times they are in two minds as to what to do, whether we should discontinue amoxicillin and only continue oseltamivir, or you continue both these in this child. So what would be your advice to our colleagues?
Sir, as you said, it is a very dicey situation. In practically, we would generally will continue the antibiotics along with the antiviral because many of the influenza virus patient, in viral patient also there is a superadded bacterial infection. But in some cases, if there is you are 100% sure that it is only viral, then only we can stop antibiotic. But in practice, it is very difficult, sir. So 30% of generally viral infection or influenza patient may have a added super added bacterial infection. So we should also always keep that thing in mind, sir.
Yes. So depending on the individual case and depending on the clinical presentation and the laboratory parameters, we can take the call. However, if the child is responding very well to oseltamivir, and then in case if the trial with antibiotics has already failed and the child is responding well to oseltamivir, then maybe you can decide and continue only oseltamivir. But it all depends on the clinical presentation. So our colleagues can take the decision accordingly. And Dr. Keyur, many times, when the diagnosis in doubt, we have to send the throat swab or the nasopharyngeal swab for testing for this flu virus. Okay, these days there are various panels also available, and sometimes we get influenza virus positivity. Sometimes we don't get positivity. We get some other virus like rhinovirus. But on one side, the child is, showing very high fever and some systemic signs, as I told you. So many times this situation also becomes dicey. So I would like to have your opinion as to if the influenza virus is positive on the throat swab, then how far is it reliable? Whether if it is positive, and then in case even if it is negative, then both the reports. So how will you look at positivity and the negativity of the reports when they are in relation to H1N1? And secondly, if you get other viruses like rhinovirus, etc., how would you look at that situation?
Yes, sir. So, nasopharyngeal swabs, what we are saying routinely, there are certain problems with technique of taking those swabs, because there are two swabs should be taken, nasopharyngeal and oropharyngeal swabs that will be taken. Now, in pediatric patients, when the kids is smaller, so it's difficult to make them say ah and simultaneously push tongue down and take swab from the posterior pharyngeal wall. Okay, so the technique is itself difficult, but still, if it is taken very properly, then the sensitivity and specificity of nasopharyngeal swab for influenza is very high. It's above 90%. So if it is positive, it is definitely positive. You have to treat it. Okay, so it's not bystanders. What you can say bystander. So when on nasopharyngeal swab, certain viruses, if they are there, they are definitely pathogenic, like influenza, parainfluenza, metapneumovirus. These viruses should not be taken as a bystander. They should be taken as a definitely uh, causative organism. Okay, but other viruses, if they are present, like Boca viruses, adenoviruses itself, or enteroviruses, they should be taken with pinch of salt, because adenovirus can remain longer also in the nasopharynx. So we have to take that also in mind. Second thing, if, as you said, if the swab is negative, but still the child is showing influenza-like illness, very high-grade fever and symptoms, WHO itself says that in category B, if there is high-grade fever, severe sore throat, influenza-like illness, there is no need to wait for testing. You can treat him directly with oseltamivir. So in such patients, though we are sending swab, we can start definitely treatment directly. There is no need to wait for report to come, and our treatment should not differ depending on report, because though the sensitivity specificity is very high, how the swab is taken is also important. And if you are very sure clinically that this is influenza-like illness, you should start with oseltamivir. No problem with that.
And one last
And
question to you.
regarding
Yeah,
yes,
you continue.
yes, sir. Yeah. So regarding what we were discussing about secondary bacterial infections, nowadays what is happening, Pune is having so much surge of viral infections. So even in IPD patients, we are not in a hurry to start antibiotics. We are giving them hydration, we are giving them oseltamivir, and we are sending family. They are positive. We are managing them without antibiotics also. They are responding very nicely, because such a high epidemic is going on. So if the counts are viral, if the CRP is negative, and if you are sure the is clinically influenza-like illness, we can still manage on oseltamivir. And if at all the child is not responding to oseltamivir after 48 hours, because you have started oseltamivir, the swab is positive, you have started, and even after 48 to 72 hours, child is not responding, then you can think that there may be secondary bacterial infection. Why? The child is not responding to oseltamivir. Then in that cases also, you can think of adding antibiotic if you are not added earlier.
Okay, that's good. Anyway, now only one last question. Sometimes we get two viruses which are known to produce low respiratory infections of severe degree. Like one of them is say H1N1, and other is say RSV, respiratory syncytial virus. So when you get when you get two viruses like these, then how do you look at it? How do you manage them? And what is your plan of action?
So we are getting actually kids with both positive right now in this current epidemic. We are seeing patients who are coming with influenza A positive also, and RSV positive also. So, but we are treating them symptomatic. We are starting them with oseltamivir, and for RSV, the symptomatic management is also only there. So there is no, we are not definitely giving any antiviral for RSV. For RSV part, we are managing them as a usually like an acute bronchiolitis, supportive management, hydration, humidified oxygen, and all those things. and simultaneously we are giving the oseltamivir because influenza is positive. So yes, as you said, both positive patients are also there.
Right. Anyway, thanks for clarifying all these situations related to flu, then co-infection with other bacteria and co-infection with other viruses, also rational use of antibiotics and specificity and sensitivity of these tests. Okay, so we can understand that the flu is a fast and a furious virus, because the onset is abrupt, the transmission is high, the progression is also rapid, and ARDS develops very fast, and oseltamivir also has to be given very fast. Okay, and right from the days of COVID, this short form SMS has become very famous, where we are going after this social distancing and mask and sanitization, along with coughing etiquettes. Everyone knows now that one has to cough in the elbow, and he has to follow what is called as this Hasta Pancha Sutri. I call it as, all those 5 things starting from the alphabet H, like hand washing, hand shaking to be avoided, handkerchief to be used, hands distanced from the other person, and, avoiding the hand touching. So all these are very important things. And that's why we all should take the preventive measures, including the vaccination. And we all know that the annual influenza vaccination is something which is very, very important, a preventive step. Okay. So all in all, it's very important that we know all these details about influenza, about the virus, the clinical presentation, the complications, the early use of oseltamivir, and what are the regimens and the dosage schedules, and the problems associated with certain cases where we should all be alert about different clinical scenarios. So, Dr. Sainath and Dr. KU, I thank you for your elaborate discussion related to influenza. And with that, I hand over the proceedings to Dr. Prashant. Thank you.
Thank you, sir. Thanks, Dr. Kayur. Thanks, Dr. Sainath. It was lovely discussing cases and new insights on influenza. Once upon a time, we never thought that this virus could be so. Initially we always start with treatment with antibiotics, but this antivirals are taking over. It's always life is changing. So thanks once again. I'm sure the audience would have benefited out of this discussion. Thanks, Dr. Zog. Thanks, Dr. Mahajan. Thanks, Dr. Pawar. Thank you, marketing team, sales team of Hitro for organizing this. And thank you, IT team. Wish you a very good evening, and we can sign off, sir.
Thank you.
Thank you, sir.
Yes, thank you.
Thank you.